Hello, good day and สวัสดีค่ะ On behalf of the Asian Pediatric Pulmonology Society, I would like to welcome you to our ninth Grand Round, which is hosted by Bangladesh Pediatric Pulmonology Forum. I would like to thank all panelists, presenters, and the most important person, that is Professor Shakil Ahmed, who is the president of Bangladesh Pediatric Pulmonology Forum, for their devoted time and effort to make this grand round happen on a volunteer basis. And before I will hand the microphone to Professor Shakil Ahmed, I would like to tell you a little bit more about the earthquake happened in Bangkok, Thailand. Despite there are some buildings that were collapsed because of the earthquake, right now most of the area in Bangkok is safe to live, and because we are sure that our venue hotel is intact, as I will like to show you on the pictures here. Could you please visit, show the picture of our hotel venue? Okay, this is the hotel venue that it was taken just an hour ago. So because the venue, the building of the hotel is very strong and newly built within 2 years, so it is safe to come to the conference or the congress. So we have to make sure that our congress will go on as scheduled. So I would like to welcome you all to the APPS TPRC Congress 2025. So right now, I would like to give the microphone to Professor Shakil Ahmed.
Thank you very much. So on behalf of APPS and Bangladesh Pediatric Pulmonology Forum, I now welcome all the participants from around the world. About 650 has registered. So far, 107 has joined by this moment. And the 24th March was World TB Day. On the verge of those days, we are in just a moment to write case with tuberculosis and novel presentations and solutions. And as we all know, that tuberculosis affects 1.25 million children around the world, killing about 100,000 or more. But the diagnosis of childhood TB is only 70,000 in 2023, and rest are undiagnosed, untreated, and there is chance of mortality. In this situation, the tuberculosis, which is a high burden country, is high burden in different countries of Asia, Africa, Latin America, and so on. So for that, today we have chosen this tuberculosis. TB can be protein disease. It can affect from anything. We know traditionally it should be a tweaks, fever, and cough. It can be debated from that. So our today's presentation theme is novel presentations of tuberculosis and the solutions. May I now, today we'll be having two cases. One will be presented by Dr. Sharabun Tahura, and next, Dr. Khalid Hassan. May I now request Dr. Sharabun Tahura, who is the interventional pediatric pulmonologist in Bangladesh Shishu Hospital Institute, to present our case. Sharabun Tahura, please.
Thank you very much. Hello, everyone. I sincerely thank APPS and Bangladesh Pediatric Association, Bangladesh Pediatric Pulmonology Forum for this chance to present the first interesting case of today's grand round. It is the story of a 7-month-old boy who came to our OPD with the complaints of a cough for 10 days and fever for 3 days. The cough was non-productive and not associated with breathing difficulty or feeding. The fever was low grade, irregular in nature, and without any diurnal variation. Though the child was born at preterm with low birth weight, he did not develop any postnatal respiratory problems. He was routinely immunized, and on that day, we found the child was well thriving, having a low grade fever, but there was no respiratory distress. There was some bilateral crepitation, which was more marked on right side. On the third day of the illness, the child was seen by a private practitioner. He prescribed oral cefixime along with syrup and Broxol. Despite completing a 7-day course, the child did not show significant improvement. And that time, the extra chest was advised, which revealed consolidation in the middle of the mid zone of the right lung. These findings raised concern for a potential underlying infection. The child was advised for hospital admission. And at the 10th day of illness, the child got admitted in the hospital, and the injectable ceftriaxone was started to provide broader antibiotic coverage. During hospital stay, the child was afebrile, but cough persisted. It became more intense later on. On the 8th day of illness, the child develops dyspnea. That time SpO2 falls at 90% on room air, and it improved up to 93% with 3 liters of oxygen. On examination on that time, dullness on percussion was noted over the right upper chest, and breath sound was found absent in the same area. Given these findings, a further chest X-ray was advised to investigate the cause of the worsening of the symptoms. That X-ray was taken at the 18th day of illness. That time, child completed the 7 days injectable ceftriaxone. And you just see that there was the homogeneous opacities occupying the upper and the middle zone of the right lung. Apparently looks like a consolidation, as there was no medicinal shifting. However, the absence of air bronchogram suggests that the dense opacity may not be the typical pneumonic consolidation. Upon a closer inspection, narrowing of the air column is noted at the lower part of the trachea and the right main bronchus, including compression. When we compare this X-ray with the one taken on the 10th day of illness, we observed a clear radiological worsening of the condition, indicating a progression of the disease. At that time, a CT chest was advised for better understanding the extent of the condition. And CT chest revealing that the large consolidation with necrosis in the right upper lobe associated with necrosed mediastinal lymph node. And it is the mediastinal window of the contrast CT, and it is the parenchymal window of non-contrast CT. And at closer examination of the parenchymal window in the non-contrast CT, it reveals dense opacification in the right upper lobe, causing bulging of the horizontal fissure. There is no air bronchogram present. Additionally, the compression is noted at the opening of the right upper lobe bronchus. And if you see the contrast in his mediastinal view, showing scanty vascularity in the upper portion with a few internal arteries visible. The findings are consistent with the expansile pneumonia. At that time, upon further inquiry, the mother mentioned that the child's new caregiver had been suffering from cough for around a month. However, tuberculosis workup was not conducted as the caregiver was fired from the job. So at that moment, we advised for the TB screening and all was found normal.
Oh, now if we go for a full question for the audience, you heard the story. Please proceed for the full questions of your answer. We'll provide 30 seconds of time. Well, so far, okay. So if we not, so there are. So full question means it's we can see that the R is a gene expert from stool exam is one, and but bronchoscopy and ball was given 23 out of 34. Okay, let's proceed. Now may I request Dr. Reena Triashi to further dissect the situation of the case. Reena is a faculty working in University of Gajah Mada and Dr. Sarjido Hospital in Yogyakarta, Indonesia. She has been a long veteran in the field of childhood TB. And may I now request Reena, can you please proceed with the discussion of the case and the case review? Reena, it's up to you.
Okay, thank you, Professor Sahil Ahmed, and hello, everyone. I will start the discussion by reviewing the case. Okay, sorry, I cannot control the, okay, anyway. Okay, so I would like to make a brief summary for the cases that has been presented by Dr. Sarah Bond. So here we have a young infant who was initially treated for community-acquired pneumonia. Although cefixime is not the optimal choice for community-acquired pneumonia, this patient later on received ceftriaxone, which actually already provides appropriate coverage for the etiology of community-acquired pneumonia, except for Staphylococcus aureus. However, in this case, a staphylococcal infection appears clinically unlikely. So we can say that this patient actually has been treated adequately for community-acquired pneumonia. However, the pneumonia in this patient is worsening. This brings us to the diagnosis of non-resolving pneumonia, which is defined as a persistence of symptoms and radiographic abnormalities for longer than expected, even after adequate treatment given. There is no clear consensus about the exact time when we can say that this patient having non-resolving pneumonia. However, there is a general guideline is that radiographic infiltrate in a patient with community-acquired pneumonia should be improving significantly within 2 weeks and largely resolved within 4 weeks. If there was a lack of at least partial resolution by 6 weeks, so it warrants to have further investigation. Before we order some investigations or workup to identify what is the etiology of non-resolving pneumonia, So it is very important for us to do a careful and comprehensive review of clinical and radiographic history, also to assess the response to the treatment, so we can identify or determine what is the more likely or the most likely etiology of the non-resolving pneumonia, which can be infectious or non-infectious. The infectious causes can include resistance of the bacteria, unusual pathogens, or maybe a fungal infections or mycobacterium such as tuberculosis infections. Whereas for non-infectious causes, it can be endobronchial obstruction, non-infectious inflammatory conditions like asthma, ABPA, or hypersensitivity pneumonitis, congenital abnormalities, or immunodeficiency. Now let's review the radiological findings that has been described very complete by Dr. Sarah Bond. As we can see here in the second X-ray that was performed 18 days after, of the illness, we have here the dense opacification on the right lung, and we can also see here the obstruction or the narrowing of the airway. The dense opacification here is also accompanied by the bulging of the fissure of the lobe. So it is consistent with airway with expansile pneumonia with airway compression. Expansile pneumonia is rare in children. So different of fragment, which result in a densely consolidated lobe or segment with bulging fissures on chest X-ray. So the bulging fissures is one of the characteristic of expansile pneumonia. The most common cause of the expansile pneumonia is Klebsiella pneumonia or Staphylococcus aureus. Mycobacterium tuberculosis can also cause this condition, even though it's uncommon. In this case, now which is more likely to this patient, whether this pneumonia is caused by the pyogenic microorganism or the Mycobacterium tuberculosis. The complete blood cell count in this patient saw non-neutrophilia, and initially this patient had much less symptoms as compared to radiological lesion for an acute pneumonia. And at the end of the story of this patient, he deteriorated later despite of the fair use of antibiotics. And one thing that we also have to consider is that this patient living in an endemic area of tuberculosis. So the cause of Mycobacterium tuberculosis is more likely than the pyogenic causes. Now I would like to give some review about the expansile pneumonia due to tuberculosis. There is no clear pathogenesis, but this is one of the proposed pathogenesis of the expansile pneumonia due to tuberculosis. It is started by the rupture of the necrotic lymph nodes near the airway, and then it will lead to the endobronchial spread of the tuberculoprotein, which will cause a hypersensitivity response and leads to a dense consolidation in the parenchyma. As the disease progresses, there will be severe to complete obstruction of the airways with cascading necrosis of the lung parenchyma, and it will also lead to the formation of the vocal cavities here. Publications about expansile pneumonia due to tuberculosis is very limited. And this is one of the report from South Africa, which has 24 African children. And here they documented that the most common clinical presentation is non-resolving pneumonia. The other non-specific clinical presentation can be such as the persistent lobar collapse and then the large airway obstruction with unremitting monotonic wheezing can also be manifest as extrapulmonary TB, such as convulsion and meningitis TB. The history or evidence of infection, which can be identify from the history of contact or positive tuberculin skin test is not always found in patients with expanded cell pneumonia due to TB. But the culture positive for Mycobacterium tuberculosis is quite high in this situation. Chest X-ray, I think it has been discussed very clearly by Dr. Sarah Burns. So once again, there will be a dense opacified of the lobe, the affected lobe, and there will be also the bulging of the lobe of fissure. Chest X-ray is not, in this situation, is not a good tool to identify the enlargement of the hilar lymph node. However, it can be identified indirectly from the compression of the airway. And thus the CT scan, it can give us more information about the opacification, about the necrotic area, the obstruction of the airway. And with the CT scan, we can also identify the enlargement of the hilar lymph nodes, the tracheal compression, and also the other lymphadenopathy and cavitation can also be seen here. So now I offer to you again, Dr. Sarah Bourne, for the next investigation in this case.
Dr. Sarabun, please proceed with the next slide, because the participants poll says that bronchoscopy should be done. Yes, we can see that bronchoscopy is there. Sarabun, please proceed with your
We
next
found
slide.
that 68% participant recommended proceeding with a bronchoscopy. Yes, we have proceeded with a bronchoscopy too for the further evaluation. Just look at the video. Here we see that the trachea and the left bronchus appears normal. However, when you go into with the right lungs, right bronchus, just see at the opening of the right upper lobe bronchus, an ingrowth like mass was observed extending into the right RB3, leading to total obstruction of the lumen. And you just see the NBI mode, the center part of the growth, just showing appeared the avascular and the necrotic, which is consistent with the caseating materials, most likely due to extension from the eroded hilar lymph nodes. And if we observe that the bronchoscopic video, here a cryoprobe was used to obtain biopsy samples and to perform debulking of the endobronchial growth. And if you meticulously see that it is fully occupied, the mass fully occupied the lumen of the RB3. And if we go the lower part, it is the right, the middle bronchus and the basal bronchus, that is the lower bronchus, all are clear. And lumen is, there is no mass inside, only mass is occupied in the RB3. So we have taken the lavage from the bronchus, and the report showing there is the multibacterial tuberculosis was detected. And the histopathological report from the biopsy materials confirmed that was inflammation constant the tuberculosis.
So we have seen that bronchoscopy has revealed the final answer of this question. So what is the role of bronchoscopy in diagnosis TB in children? Let us bring our esteemed guest, the wonderful speaker from Delhi, none other than Professor Varinder Singh. He doesn't need any introduction. Professor Varinder, please proceed.
Thank you, Professor Shakil, for inviting me to be part of this discussion about a very interesting case. So bronchoscopy was a choice given by most people, but then bronchoscopy has a limited not many bronchoscopists, or it's not that easily available all over. So what to expect out of it? How does TB look like? And then maybe situations as the boundaries are shrinking, patients move from one continent, one country to another. So even if you are in a low burden country, you may have a migrant who may have this problem, and therefore it may be relevant for you to know. So the indications for this would be the diagnostic, if looking for the purpose of diagnosis of pulmonary TB, are there physical findings? They say image is worth several hundred words. So what do you see on the bronchoscopy in a case with pulmonary TB? Most often thing is that you see a lymph node compression, you see a extraluminal compression, which you assume to be because of a lymph in a high burden country, or from based on your imaging, which has already told you that there is a mass here. There's nothing to tell you that it is a lymph node. It just shows you a luminal compression. Sometimes this would ulcerate, and this lymph node will produce caseation, as Dr. Tahura showed us a little while ago, and I'll be showing you some more of that. To identify endobronchial involvement, bronchoscopy is the gold standard. You may have some complications of PTB like a bronchoesophageal fistula, not common, very rare, but which can be identified. So those fistulations is something else you can see. More often than not, you're doing a bronchoscopy to collect samples for bacterial confirmation, because the common indications for doing a bronchoscopy is a persistent or a non-resolving pneumonia. So all your options are open. The epidemiology may suggest that it could be TB, but there are many other reasons, and therefore you want to test specimen from the respiratory tract and send that for all possible tests depending on the milieu you are from. Specifically for TB, you can do a smear, what is called as a Zeal-Nelson smear or ZN smear. But in current time, when we have much more sensitive molecular tests like Expert or TrueNat, that is what is something which we use. We do a Expert MTB RIF, which also tells us it's a nested PCR. So it will also tell you whether there is RIF resistance, and that's important because your choice of anti-tubercular drugs regimen are distinct. If it is a RIF resistance, you go the MDR way. If it is RIF sensitive, you can still try drug sensitive regimens. And culture, obviously, the gold standard, and that is what will give you the phenotypic as well as maybe use a molecular diagnostics for get knowing the rapidly knowing the drug sensitivity of the isolate. The other samples which may be used is that if you have an endobronchial lesion, you could even biopsy that, and you send that biopsy material also for all of these tests in addition to a uh, uh, histopathology. With the advent of molecular diagnosis, histopathology is much lesser relied upon, but as you do not have, it is not like a on the site evaluation as you have a rapid on the site evaluation for a cytopathology. You would send specimens for everything. So you would send specimen for cytology, histopathology. You would also send specimens for microbiology. It's often in the past, an alternative things which we used to employ was a transbronchial needle aspiration, which was a blind procedure, which could be done for certain specific lymph nodes, like a paratracheal lymph node on the right side particularly. So there are stations which are clearly identified where you can do a blind needle aspiration. However, in current times, endobronchial guidance and endobronchial ultrasound guided FNA is something which is much more commonly used. However, the trouble is that if you have such a small child as this one, EBUS would be too large. You can do an EBS maybe at the age of 7, 8, 9 years, but not in a younger child because current EBUS size is very big. In a younger child, people have also tried using EBUS for a trans esophageal aspiration because it's a large subcarinal node. So you go through the esophagus, which can take even a younger or a smaller size child could take that endobronchial ultrasound, and you could identify and use that. Okay. So going further, what is its role in management? So people have said that you can use to identify how much is the endobronchial involvement, and if it is obstructing almost fully, which often is visible on also on radiology, but it could be one of the ways which decides that okay, corticosteroids are definitely needed. Uh, there is no RCT which has shown benefits of corticosteroids in endobronchial and how far it works, but it's intuitive for us to say that, okay, it's at the verge of obstruction. If you decrease inflammation, the airway will be more patent. So you do not use steroids, perhaps in every endobronchial, you do not do bronchoscopy to identify small amounts of endobronchial granulation in every child. But when you have expensile pneumonia, like the present case, or you have signs of obstructive emphysema, perhaps you will go ahead and do it. And you may sometimes even have to use a surgical decompression in those situations to get a lung which is now ventilating better. We had this child acutely deteriorating, and that could be because of a large ulcerations or a large caseation going in and blocking the airway. So those are something areas where bronchoscopy will definitely be useful in identifying or even doing an intervention. So people have even done debulking of lymph nodes using endoscopic enucleation or using cryo to pull out the caseation which is there. This all has been is in the published sphere. Uh, as a sequelae or even an acute case, often in an acute case you would not do a dilatation, but as a sequelae, once you have given initial therapy, one may use interventional bronchoscopy for dilatation of bronchial stenosis, for closure of bronchoesophageal fistula or bronchopleural fistula, or even for management of hemoptysis, where people have, if it is localized, they have used glue, fibrin glue, or cyanoacrylate glue to block it. People have used silver nitrate to block the fistulas. So there are several sets of papers on this, but the interventional expertise for or experience for these situations is rather limited because the disease is more in the poor nations where the availability of these techniques is poorer. So there is a kind of a mismatch and therefore the experience is limited. That was the broad indications. Quickly taking you through what are the reported abnormalities. They vary as per indications for evaluation. So if you look at the published literature, you would find several things. If you were doing a pulmonary TB, every child of pulmonary TB going undergoing endoscopic evaluation, your pattern of abnormalities will be different. If your indication is to look for endobronchial obstruction, obviously then you will find more of obstruction because that was clinically thought of. So nearly 49% of children with pulmonary TB, nearly half of them would have an airway abnormality. Not every child with a pulmonary TB would have an airway abnormality. So nearly half. So it's a good rule-in test, but not a good rule-out test in any which way. The commonest abnormality you see, as I said, is an extrinsic airway compression, usually less than 50%, but severe more than 50% may be seen in about one fifth. And that's as per one of the studies. As I said, it all depends on what is the indication for evaluation. The commonest airways which are affected are the bronchus intermedius, which is very common, followed by left main bronchus and tracheal because of the paratracheal lymph nodes. Right main bronchus can also be compressed, but it's less often. It's the bronchus intermedius rather than main bronchus which gets more involved. So this is how typically an obstruction will be seen, like a slit-like. The mucosa is looking little edematous, but there is no significant pathology there. The degree of obstruction may vary, as we can see both the places, the right-sided bronchus, which is obliterated, it's almost 90% done here. It's about 70% obstructed here. But you can also appreciate in these that there is also a canal widening. You could also see uh, on bronchoscopy the dilatation of bronchi with an ulceration or a whitish granulation. You may only see some secretions coming from a dirty dilated one. Many a time you see these kind of atrophic and highly dilated bronchus, where normally, as we see, as you go down, the bronchus are tapering. Here they do not seem to be tapering, they're wide open, and that's very typical of a bronchiectatic change, and TB is one of the common. Looking at this, you can think of tuberculosis, but you can't prove it or say that it is diagnostic, because even a post-infectious sequelae could produce a similar situation. But in a patient where you see, in addition to this dilatation, a caseation or ulcerations like this, or small fistulations, then you know it is more likely to be tuberculosis. Mind you, sometimes the just the local necrosis, even in a malignancy, can appear pale, and we may confuse it with white caseation. So be a little mindful of that, because caseation is a ultimately a diagnosis which is histopathological. But what you see is a cheesy white material which is very clear. Then you are almost certain, can't be 100% certain, in a given setting that you are likely dealing with tuberculosis, and this is what the index case also showed. How do the bile perform for MTB culture? While when we look at the bile for MTB culture, studies have shown that the culture yield is significantly less than that from gastric aspirate. So that is why bile is not your first test. And even in the index case also, they first tried stool and gastric wash. When it was negative, then only they decided to go for a bronchoscopy, and there were other indications in this case. Some studies have revealed, though isolation rate, including one from Delhi, our own, that while the isolation rate from the BAL was comparable or GA was better, but actually, if you use both, the cumulative yield increases. That means many of the patients who are negative on gastric aspirate may be positive on BAL, and some of the patients who are positive on BAL may not be positive on gastric aspirate. So, repeating the test sometimes gives you some additional yield. With this molecular test coming our way, things have evolved. Now we are talking of a much more efficient diagnosis than MJIT, which takes longer, and ZN smear. So expert results are that on BAL, they perform better, and many times even when the MTB culture on gastric aspirate is negative, it is better on BAL. So I'm talking of MTB culture gastric versus BAL. I'm not talking of expert on BAL versus culture on BAL, in which case BAL culture performs better. But if we compare the culture from gastric aspirate versus CBNAT on BAL, the BAL adds efficiency, and this has been studied, shown in several studies. The study from AIMS showed that there was an additional yield by the expert in BAL fluids by about uh, 25% to 30%. Different studies have shown different data. The South African studies showed that if you use combination, the while 62% were positive by both, it was expert which was more positive in 35%. And I think where we have ultra, perhaps this yield will increase further. The people have also seen what kind of lesions on X-ray will give you better bacteriological yield. So when you have pneumonia, expansile pneumonia or airway compression, you are more likely to get a bacteriological confirmation on BAL, and this is something which has been shown. This is one technique which is also used to determine the cause of treatment failure. Because if you have a persistent cough or a collapse, airway involvement, it may not always be because of active disease, particularly in a child who's on treatment and the constitutional symptoms are improving, but X-ray is not resolving, cough is not resolving. Then the obstruction may be because of the residual polypoidal mass or granulation tissue, which is also amenable to maybe laser, cryo, or enucleation, and does not require any kind of therapy. People have also used steroids. It may be because of extrinsic compression by the large tissue which is there. It may also be because of obstructive caesium, which may not necessarily in this situation be because of active disease. This may also be a reflection of a caesium which has not been brought out, which was retained inside, but has become sterile with our use of anti-tubercular drug. Intradermal granulation tissue or mucosal ulcerations are other things which you see in a child who has been on treatment. So, flexible bronchoscopy can provide us several clues about what could be the possible reason for those airway involvement in a child who continues to have either a bad x-ray or cough, though the systemic things are improving and it seems to be the patient is responding to therapy. So there are therefore several ways a bronchoscopy adds to our assessment. I did talk about aspiration biopsy to begin with, but this is not relevant for the current case because it's a very small child where EBUS is not possible. Yes, a blind TBNA could have been done. Endobronchial tissue as a source for culture and even for a microbiological diagnosis is something which is acceptable and has been tried. However, there are very limited published literature on that. So this is something which is there for the large airways. I will quickly touch one slide on one another part of tuberculosis, which is very rare, but is something which is something which you can diagnose on bronchoscopy or airway evaluation alone. So typically, these children who have laryngeal involvement because of tuberculosis, they will mimic an upper airway obstruction, where more common causes are retropharyngeal abscesses or diphtheria, and which occur because of respiratory distress, stridor, or altered or poor phonation. Bronchoscopy is very essential to confirm diagnosis and determine the extent of the involvement in these situations. And you can see extensive swelling of the epiglottis and larynx in these situations. So this is all from my end on how far an airway evaluation can give us clue about there being tuberculosis as the cause of the persistent symptoms or persistent pneumonia, or when you are looking at reasons for failure in a treated case of TB. Thank you. Thank you very much.
So, thank you very much.
So before that, before Shravan is going to tell, there was a chat question for Varinder.
Yeah.
Can you just respond to that?
Okay, I'll check.
Yeah.
I'll
How do
see.
you explain ball having less culture positivity than gastric washings?
Okay. So one of the reasons is that the gastric aspirates are collection of secretions over a period of time. When you go in for bowel, you are collecting, you may or may not reach, if you have a proximal, abnormality, this is the diseased area. Often, you may not reach the segment where there is enough endobronchial involvement for you to get a yield. So that's one of the reasons why the bowel may give you less yield than gastric aspirate. And secondly, as I said, gastric aspirate is collecting yield over a much longer period because it's an overnight fasting. You may have intermittent opening up or secretions which are coming from the involved area. When you're doing bronchoscopy, it's one time cross section, that few moments secretions. If the child has already coughed out something, the airway may not be that having that much of bacilli at that point of time. With molecular diagnosis, this may shift little bit. It is showing a shift. Yet, gastric aspirate, because you are collecting a large amount of secretions, would stay. Another problem with bowel is because when you don't see anything, you are lavaging large amount of areas. You will intuitively do a lingular and a right middle lobe. You may do other bronchuses which look like lobes which look involved on radiology. Now, this is diluting the secretions. And the yield on a molecular diagnostic is number of DNA copies per ml of fluid. So you have already diluted it, and that can also further decrease it. So those are the reasons why there may be differences. Thank you.
Thank you, Varinder. WHO has said the same thing. If you collect ball by one sample, then it gives equal or less result than gastric washings. So may I
Yes.
now request Saraban, please proceed with your final slides.
No.
What happened to
Thank
the
you
child?
very much, Professor Barinder Singh, for his nice talk on the enterobronchial TB and the rational use of the bronchoscopy regarding case. So, but all of you know that our case don't have any significant typical history for the TB, and all the TB screening from the gastric lavage and the MT was negative. And finally, we come to the diagnosis after doing the bronchoscopy and bronchoscopic collection and of the mass that reveal the it was the endobronchial TB. So finally, we diagnosed the case as the expansile pneumonia due to endobronchial tuberculosis. And after that, we have started the anti-TB medication with the 3-FDC with ethambetal and oral penicillin tapering for the next 6 weeks. And if we see the X-ray that was taken following the 1 month of anti-TB treatment, just you look at the X-ray, the compression of the lower part of the trachea and the main bronchus resolved completely with the significant resolution of the dense opacity. And if you just see the X-ray that was taken after 2 months of the anti-TB treatment, it is just near normal. It is almost normal. So after taking the anti-TB drugs, the child radiological improvement and there was the clinical improvement was noted.
Okay, thank you, thank you. So now we'll be going to the next case. Our presenter is Mohammad Khalid Hassan. He's a very young physician working in RCDDRB as a physician. Khalid, can you proceed with your case?
Thank you, Professor Shakil sir. Thanks to APPS and Bangladesh Pediatric Pulmonology Forum for giving me floor. Good evening, everyone. Today I will share the second case. The second case is about a 11-year-old girl from Bangladesh. She was admitted to Dhaka Hospital ICD-DRB with the history of multiple swelling all over the body for the last 4 months. She is a known case of tuberculosis and has been on regular medication. Her immunization was completed as per API schedule and BCG mark was present. And she has no history of consanguinity or recurrent infection. Notably, she has a history of close contact with TB positive case from her maternal uncle. On examination, her weight was 25 kg, respiratory rate was 20 breaths per minute, lungs was clear, and there was no lymphadenopathy. On examination, there were multiple swelling all over the body, with the largest one located on neck, chest, and buttock. The swelling over the buttock measured approximately about 18 by 16 centimeter, and it was tense, non-tender, and had a sinus formation. The chest swelling was about 6 by 4 centimeter, while the neck swelling measured 3 by 2 centimeter, and both sharing the similar characteristics. Here is some pictures of the swelling with measurement. Now, let's go back in time to explore the child's past medical history. On June 2022, she was admitted to tertiary level hospital outside the Dhaka city with the history of fever for 1 month and cough for 2 months. Cough was initially dry, later it became productive. On admission, her physical examination revealed a high temperature of 101.2 degree Fahrenheit, and respiratory rate was 25 breaths per minute, and there was sign of left upper lobe consolidation. There was left-sided cervical lymphadenopathy, which was measured about 3 by 2 centimeter of diameter. Her body weight at the time of admission was 20 kg. To determine the cause of fever, cough, and lymphadenopathy, a series of investigations were performed. In CBC, hemoglobin was low, 7.8 gram per deciliter, with leukocytosis and high ESR. Chest X-ray revealed consolidation in the left upper lobe with mild pleural effusion. An abdominal ultrasound revealed multiple lymphadenopathies in the para-aortic, peripancreatic, and para-portahepatic region, with the largest measuring was 30 by 17 millimeter. Additionally, multiple hypoechoic splenic lesion ranging from 5 to 7 millimeter of diameter were observed. Triple antigen was negative and serum ferritin was normal. As there was no specific clue from the previous investigation, so they performed lymph node biopsy. That revealed granulomatous lymphadenitis. They also sent the sputum for gene expert that was positive for Mycobacterium tuberculosis with no resistance to rifampicin. So on the basis of history, clinical examination, and investigations, they diagnosed her as a case of disseminated tuberculosis. Following the diagnosis, treatment was initiated with a standard anti-TB regimen with 3-FDC and ethambutol for 2 months, followed by 2-FDC for the next 4 months. Her treatment compliance was good, and on follow-up in September 2022, her fever and cough had completely subsided. However, later on January 2023, she returned to that center with a 3-week history of fever, multiple swelling in different parts of the body for the last 1 month. They did the FNAC from the swelling, and it revealed granulomatous lesion consistent with tuberculosis. As a result, her anti-TB treatment was restarted with 3-FDC. That was all about the past history of the girl. Now, coming back to the patient's presentation at Dhaka Hospital ICD-DRB, we performed an aspiration of 150 ml of pus from the buttock swelling for further analysis. So to determine the underlying cause, a series of investigations were conducted. CBC, chest X-ray were normal. Sputum for gene expert, we sent the sputum for gene expert, that was negative, but pus for gene expert ultra was positive for tuberculosis. We did the HIV screening, that also was negative. We also sent the immunological panel, which was essentially negative for all the markers. So if I say the summary, she was an 11-year-old girl with a known case of disseminated tuberculosis, presented with multiple recurrent abscesses despite of regular anti-TB medication for the last 8 months. All physical examination was normal except multiple abscesses. Aspiration from the buttock swelling showed cheesy pus. It revealed Mycobacterium tuberculosis with gene expert ultra, and rifampicin resistant was absent. Immunological panel report was normal. HIV test was negative. So we performed the gene expert multiplex for NTB, so it was negative. And further, we did the line probe assay that revealed that stain was sensitive to first-line anti-TB drug. As immunological panel HIV test was normal, we decided to check the gamma interferon level, which was within the normal range. And unfortunately, we couldn't manage to do the gamma interferon receptor as because it was not available in our country. So based on the clinical presentation, examination, and investigations, the diagnosis stands for variant of Mendelian susceptibility to mycobacterial diseases or maybe disseminated TB due to gamma interferon deficiency.
Thank you, Professor Shakil. Well, shall I proceed with the discussion?
Yes, please. I think it's time for discussion.
Yeah, thank you. I will proceed then. Thank you so much for inviting me. It's a great pleasure to be here. And I will give a short review of MSMD, which is Mendelian susceptibility to microbacterial infection, in relation to our patient in case 2. This 11-year-old girl, why should we have so many cases of mycobacteria TB? Why should we think of MSMD, which is actually a monogenic disorder with susceptibility usually solely to mycobacteria, but not always the case. And in this patient who is 11 years old, had no previous history of infections until June 2022. However, once she's got infected with TB, she had a very unusual presentation following disseminated TB and then skin abscesses in the form of pus. And I think we need to think of MSMD whenever you have a presentation that is so unusual and so widespread and recurrent. At 11 years old, should she present earlier with this kind of immune deficiency? Actually, MSMD can present at all ages. Many patients present in infancy with disseminated BCG after BCG vaccination. However, adults also can present with MSMD, and so we appreciate that this spectrum of disorders can vary quite a bit from very severe to milder forms. A family history is always important because these are monogenic disorders. And for this patient, there's no family history of note, but it doesn't exclude MSMD. Now, to appreciate this group of disorders, this is a figure to show you how we understand our protection or our immunity against mycobacterial infections. And the most important circuit here is actually gamma interferon immunity. It involves the innate dendritic macrophages over here, as well as the T cells. And the crosstalk here is very important to be protected against mycobacterial infection. Up to date, maybe over the last 30 years or so, there is described 22 genes that can confer MSMD. And you can see that it is quite a complicated pathway. Some of these disorders are actually very rare. You can see in red here those that are isolated MSMD, and there are some syndromic ones where they may present with skin abnormalities, with neurological disorders as well. However, the most common of these disorders that have been described are actually the IL-2 receptor, the beta receptor, as well as the interferon gamma receptor. And these two lots of disorders can present with mycobacterial infection. And the interesting part is that particularly the IL-12 and the gamma interferon receptor, these two disorders have very variable penetrance, and the phenotype is quite variable in the sense that some within the family, some can present with very mild disease and some can present with very severe disease. This is I took this map from a recent review, very recent one. I think it was last year that it was published. And the authors actually trawled the medical literature. They found 150 articles and altogether 800 over cases. This is just to appreciate that the darker pink ones, which is the Middle East and India, these two regions have the highest number of cases of MSMD that have been reported. Possibly it's because of consanguinity, but perhaps also ethnicity may play a role. So our patient actually had Mycobacteria TB, and this is a very common bacteria, but our patient's presentation is very unusual. Therefore, MSMD is important, but we need to appreciate that patients can present with disseminated BCG and other forms of non-tuberculous mycobacteria. Particularly, there may be some family members that actually present not with mycobacteria infection, but with non-typhoidal salmonella bacteremia. And this may be a signal to you to look for MSMD in such patients. And quite a variety of patients with certain disorders within that pathway may also have fungal as well as viral infections. Our patient had normal laboratory tests, and the initial immunological evaluation in MSMD is typically negative. You get negative results. You may want to look at antibodies. You want to look at lymphocytes. You look for acquired disorders, like this patient had her HIV test done, and they come back negative. You need to suspect MSMD if the presentation is suspicious. There are tests that you can specifically look for MSMD disorders, and one of them is a functional test to look at this pathway, the production of IL-12 as well as gamma interferon. And I will show you some results to give you an idea how the test is interpreted. As with this patient, we could not test the gamma interferon receptor, but by flow cytometry, you can test this to find out whether this receptor is intact. However, we also realize that you may have a normal expression, but the function of this receptor may be abnormal. And so this test may not be useful when it is normal. Another form of MSMD that we often see, probably the youngest presenting case is in adolescents, but in middle age and older patients, antibodies, autoantibodies to gamma interferon is actually a common reason to present with a MSMD-like picture. That means they only present with mycobacterial infection. And since these disorders are genetic profiling will help you with the genetic diagnosis of these patients. I'd like to just show you the functional tests that you can do for MSMD. And this test actually interrogates the gamma interferon arm as well as the IL-12 arm of this pathway of the patient. And when you take the patient's peripheral white cells, you can look at this pathway by adding mycobacteria. Usually we use BCG in the laboratory because Mycobacteria TB is pathogenic and cannot be used in many laboratories. But this patient with IL-12 receptor defects, you can see that we interrogated the IL-12 cytokine production by adding mycobacteria as well as gamma interferon. And you can see that both the patient and the control and the patient responded with an increase, although the patient slightly less of gamma interferon. When you interrogate the other arm, which is the arm of the gamma interferon, and this is the T cell response, you can see that the patient cannot respond with BCG and IL-12 with increase of gamma interferon. This tells us that possibly there is a defect here because you add IL-12 and the patient through this pathway is unable to produce gamma interferon. So this functional test may help you to delineate which arm of the pathway is abnormal. Does our patient have gamma interferon deficiency? Because the ELISA assay showed that her gamma interferon level was low in the serum. And I think that this disorder of all the MSMD, which are rare disorders, is the most rare of the collection of disorders. It's only recently reported, and it was in two Lebanese cousins. They were very ill because they had a mutation that caused a total deficiency of gamma interferon. And you can see that the authors concluded that actually the prevalence of receptor mutations are much higher than that of gamma interferon, and they think that there is because of a stronger negative selection for the gamma interferon cytokine genetically. How do we manage this group of disorders? Certainly, you have to treat with antimicrobials targeting the mycobacterial infection that is diagnosed. Subcutaneous gamma interferon for some of these defects may be useful. As we say, the gamma interferon immunity is abnormal. And if you get supplement gamma interferon, you can drive this circuit, especially those who have IL-12 receptor abnormality. There are some studies who also suggest that you can treat primary TB or disseminated TB with gamma interferon without MSMD, including aerosol therapy. However, I think in the latest review, the conclusion is still, or the consensus is still, that the evidence is not strong enough for this form of TB in the absence of MSMD. The severe phenotypes, there have been reports of a hematopoietic cell transplantation. So I hope I've given you an overview of the MSMD, and I pass you over to Dr. Khalid Hassan to go on. Yeah.
Thank you so much.
Khalid, let's take us to the last part of journey.
Okay. Thank you so much for the great discussion. So, though gamma interferon therapy was indicated, we were unable to administer it due to its high costly, and as a result, treatment was continued with 2FDC for 1 year. After 3 months of treatment, there was no note. Sir, I think the slide is changed. Can I?
You can you go up slide? Yeah, okay, go on.
Okay. So after 3 months of treatment, there was no noticeable improvement. Eventually, we lost contact with the patient. We made every possible effort to reach to the patient, and communication was reestablished on the January 2024. And we call her in-person follow-up. She was clinically well. Weight was improved to 27.6 kg. There was small swelling below the knee, but on aspiration, there was no pus. FNAC was done. That was also normal. To understand the pathophysiology, we again test the gamma interferon, and which was positive, 0.51 international unit per liter. So after 34 months of treatment, we decided to stop the therapy and continued regular follow-up. Now she is doing very well. So that's all about the case 2. Thanks all for patient hearing. So I'd like to hand over to Professor Shakil sir.
Okay, next slide, please. Okay, thank you everyone for your attention for 1 hour and 15 minutes. We are not going to discuss anymore. The first case was an acute pneumonia case, and in acute pneumonia, the study shows there were a large-scale study. It's called the bridge study. It showed that about 5.8% of all acute pneumonia in under 5 children are TB. And WHO in its statement says that 5 to 10% of all acute pneumonia can be TB. So do not just treat acute pneumonia as a bacterial one. Think TB. And second case is something which is rare, but it also shows us how little we know about the TB, TB is something where knowledge is expanding every day. So may I now request Daniel, our founder president, to speak.
Thank you very much, Shakil, for excellent presentation. I'm sure you all agree with me that Professor Shakil Ahmed has organized an excellent update on two very challenging tuberculosis cases. So thank you very much, Shakil. So for me to invite you to the next grand round on the last Friday of May, 2 months from now, we'll talk about a very interesting and challenging case of a management of childlike syndrome, childlike preterm infants, who have presented with respiratory distress as infant. So please mark your diary, May 30th, the last Friday of May, same time for the 10th APPS grand round. And also I would like to invite you to next week's meeting. So our heart goes to the people of Bangkok and wish them all well with a good recovery. And the conference will open and run as scheduled on April 2nd to April 4th, Wednesday to Friday. So I invite you all to join the opening ceremony on Wednesday. And I'm looking forward to see you all there in Bangkok. So thank you very much for your attendance. And on behalf of APPS, wish you a very happy and safe weekend, especially to my friends and colleagues in Thailand. Thank you very much. Good night.